My name is Dee Dee Cotton.
My name is Elizabeth Wickham.
We are second-year DPT students at Campbell University. Today we are demonstrating strain-counterstrain as it is applied to the high navicular on the
Strain-counterstrain, also known as positional release therapy, is both an osteopathic system of diagnosis as well as an indirect treatment for somatic dysfunction. It is a passive positional technique aimed at relieving musculoskeletal pain and dysfunction through indirect manual manipulation. An identified myofascial tender point is used to diagnose an associated dysfunction. Passive positioning by shortening tissues around the tender point is then used to relieve those points through spontaneous tissue release, resulting in decreased tenderness. It is important to note that strain-counterstrain is often used as a conjugate treatment with other manual therapy techniques to achieve maximum benefit. Within strain-counterstrain, somatic dysfunction is identified by palpating tender points. Tender points are specific points in the body that are exquisitely painful upon palpation. These postural deviations are caused by protective muscle shortening, causing a spasm that pulls on the osteoarticular structures, thus contributing to joint dysfunction. Tender points identified in extremities, such as in the high navicular bone of the foot, are actually found in the antagonist muscle rather than the muscle being strained or stretched. Tender points are caused by a muscle undergoing a sudden extreme stretch, immediately following the maximal shortening. This happens due to a high-velocity injury to the structures. The theory is that muscle continues to behave as if it was in the strained position despite the fact that the underlying joint has returned to neutral. Continuing to stretch the affected joint exacerbates the problem. Conversely, strain-counterstrain reduces the neurological input into the hypertonic muscle by placing the muscle in its maximally shortened position. This resets the muscle spindles and therefore resets the tone of the muscle. Research shows that there is both an immediate advantage and a delayed benefit to applying strain-counterstrain to manual therapy techniques when treating ankle injuries in the emergency department. Wise indicates in his research that strain-counterstrain is beneficial because it relaxes spastic muscles, reduces edema, enhances muscular recruitment, and reorganizes neuromuscular dysfunctions. Research also demonstrates that strain-counterstrain is valuable to acute patients due to its mild and non-traumatic approach. The gentleness of the technique also makes it safe and effective for treating vulnerable patients, such as the elderly, those with osteoporosis, a woman who is pregnant, someone with a fracture, or even infants. Furthermore, strain-counterstrain has applications for chronic patients due to its speed of assessment as well as its effectiveness in reducing pain and muscle guarding. Strain-counterstrain is used to treat soft tissue impairments, namely muscular hypertonicity. It addresses orthopedic disorders involving pain, fascial tension, local edema, joint hypermobility, muscle spasm, muscle dysfunction, or weakness. In the high navicular, strain-counterstrain may be used to treat ankle sprains, plantar fasciitis, or anything that causes pain to the navicular region in the foot.
When assessing tender points, make sure to assess the uninvolved side first. Joint mobility and muscle function should also be assessed before and after strain-counterstrain to identify changes in response to intervention. Due to the passive nature of strain-counterstrain, you can't really progress or scale back the technique. However, depending on the patient's presentation, the therapist may have to use alternative positions in order to achieve the optimal position of comfort for the patient. The tender point is on the tuberosity of the navicular, 4 centimeters anterior and caudal to the medial malleolus. Generally speaking, it is the largest and most prominent bone on the medial side of the ankle. Although the classic position is prone, I find that patients are most comfortable in the seated position. The clinician's knee should be placed against the calcaneocuboid joint to produce a fulcrum. Have a good grasp on the forefoot and calcaneus and then bend the foot away from the tender point. Make sure the patient is in a comfortable position, not causing stress at the hip or the knee. To explain this technique to the patient, I'm going to locate tender points that may be associated with underlying problem causing the pain and swelling in your foot. I will position your foot so the muscles are in a maximally shortened position of ease, and then apply light pressure over specific points. The goal is to relax tight muscles by reducing abnormal signals flowing from the muscle spindle. I'm going to hold this for 90 seconds to allow muscle spindle to slow its firing frequency, returning the signals to their correct firing rate. This will enable the muscles in your foot to relax and to return to their normal resting length.